How's it going, everybody? Dane Abruzzo here. Today we're going to do the first part of a two-part series on the respiratory system. So the respiratory system, obviously one of, if not the most essential organ systems to sustain life. Basic principle of it, as you probably all know just from elementary school, is that oxygen is required to sustain life. Our lungs and the environment that we live in allow us to take that oxygen up from the air that we breathe. Our heart, our lungs, our blood all combine to move that oxygen to the tissues that need oxygen to survive. At the same time, we're moving toxins and waste products in the tissues as we metabolize back to the lungs to get rid of them, also using other organ systems to do that as well. But that's the basic underlying principle of the respiratory system. As soon as that stops, oxygen transport stops, the transport of carbon dioxide back to the lungs for exhalation stops, and life cannot persist. So, of all the things that you learn in this course, this is certainly one of the more life-saving sort of techniques. When we focus on respiratory system in emergency medicine, especially in the pre-hospital setting, the best tools that we have to make a difference generally revolve around the respiratory system. So please take these lectures seriously. Please, if you have any misunderstandings or we don't make things clear, communicate with your instructors and we can clear those things up, because of anything to take home with you with confidence, it's really airway management. So to start, we're going to talk about airway management. In order to talk about airway management, we need to talk about a little bit of anatomy. So this diagram is a nice diagram kind of depicting the overall picture of our respiratory system. So we can separate our respiratory system into an upper airway and our lower airways. That's generally how we're going to differentiate. So in the upper airway, we find a few structures. First one we're going to talk about is the pharynx. The pharynx is further subdivided into the nasopharynx and the oropharynx. So this is really the exterior opening to the rest of the world. You would call it your nose, mouth, and probably part of your throat. So essentially the nasopharynx is our nasal cavity. That's the access of air that you have in through your nose. Oropharynx is through the mouth. They meet to combine as the pharynx. As we move further down, we have essentially the larynx, which right at the top of the larynx is what we call the glottis and the epiglottis. So this is the access point into your trachea. The trachea is more commonly known as the windpipe, and that's going to lead down into the main bronchus, the left and the right main bronchus. Those are subdivided further into smaller bronchioles, into their final terminal bronchioles, and then into these smaller structures called the alveoli, the alveolar sacs and the individual alveolus. So you can see that we're going from a macro scale of the openings to the external world, where we can move a large amount of air, down in through these different divisions that eventually end up in these millions and millions of tiny, tiny little air sacs that we call alveolus. So at any point along the way, if we close the airway passages, obviously the exchange of oxygen, which really occurs primarily in the alveolar level, is going to cease. So it doesn't really matter how far up, and in fact, the further up any kind of airway compromise occurs, the more severe it is for the person's health. Obviously, the further down, well, we might knock off part of the lung, we might inhibit some of the gas exchange, but the more significant and more immediately life-threatening problems are those that affect the upper airways. So a lot of what we talk about here today is really dealing with the upper airways and the management techniques, the tools that we're going to give you to help improve our management of patients with upper airway problems. So just a more detailed review of what I already gave you. The upper airway is going to be comprised of the nasopharynx, the larynx. What's not on there is also the oropharynx, the epiglottis, which is actually the small piece of tissue that is going to cover your trachea when you do have when you do go to eat food. So it's the main flap that prevents food from going down into your trachea. And just beneath the epiglottis, right in there, in the glottis is actually where your vocal cords are as well. So vocal cords are hanging out right down in here. Lower airway, once we pass through the glottis and just underneath the epiglottis, we get into the trachea or the windpipe. This guy is surrounded by these cartilaginous rings. So if you grab your trachea, you can note that you can move it around, that it doesn't feel like a piece of soft tissue. And those cartilaginous rings are there to give it integrity, to make sure that it doesn't collapse with variations of pressure. As it goes down from the larynx to the bifurcation of the bronchi, then we have the two main bronchi, left and right, supplying the left and right lungs. The bronchioles are smaller passages. These passages do have the ability to constrict and relax a little bit more than the bronchi and the upper airway. And when we get into some respiratory diseases, we'll find out why that's important to know. Again, stepping down on an even more micro scale, we have the alveoli. These are single cell wall thick bulbs of air sacs that allow for the movement of oxygen and carbon dioxide. So they allow for the exchange of gases. The main reason why they look like this, and the reason why they're so distributed in these very, very micro scale, is to increase the surface area at which we can distribute these gases. So the more places that we have oxygen molecules from the environment running by and through our air sacs, the more opportunities there are for that oxygen molecule to move across and into our bloodstream. So an important thing to note on these alveolar sacs and in this little diagram is that our lungs are not just all about air. Our lungs are all about the combination of blood and air. So we don't want the blood inside of our lungs. We know that that's bad. Coughing up blood, those kinds of things are definitely problems we have. But what we do want is blood running very, very closely, essentially 2 cells apart from the air inside of our alveoli. So in this picture we can see there's some larger blood vessels running here, and these little blue lines are essentially the capillary beds of our respiratory system. So this is where we put blood right next to air in the environment with a very, very thin layer of cells in between, which allows the oxygen and other gas molecules to move across that membrane. And so just keep that in mind throughout the entirety of your understanding of the respiratory system, that the respiratory system is not all about air, it's not all about blood, it's about the matching of blood with air in the right concentrations and in the right environment. So how do we actually move air? How does the air get from the environment into our trachea down into our lungs? Well, it's some basic physics style principles. So I'll try to use a few metaphors to kind of bring some clarity to how air moves in and out of our lungs. So you can think of the lungs as a pressure-based system. So we can either increase pressure or we can decrease pressure. And the way that we increase pressure and we decrease pressure is through the expansion or the constriction of our chest. So the main operating feature of our respiratory drive, when we're just sitting here operating normally, is a muscle called the diaphragm. So the diaphragm sits just on top of our abdominal cavity and just below the lungs, and is a muscle that can, just like any muscle, expand and contract. When it contracts, it flattens. It's going to take a nice streamlined version of itself and flatten basically onto the bottom of our thoracic cavity. As it relaxes, it's allowed to expand. It increases in volume. And so that expansion and contraction of the diaphragm is really what's forcing air in and out. So you can think of a bike pump in a similar way. As the bike pump, as you press down, as you expand the piston inside of the bike pump on the air that's inside of the bike pump, the air doesn't move from the environment or from the tire into the pump. It obviously moves from the pump into into the tire. So in the same way, your diaphragm is that pumping action. As it relaxes, as it expands, as it pushes on the airspace that's inside of your thoracic cavity, it creates a positive pressure which allows air to move out of your lungs. As it relaxes, it actually expands the space inside of your thoracic cavity. That expanded space creates what we call a relatively negative pressure, and that allows for the inhalation of air to move through the oropharynx, down the trachea, and into all the alveolar sacs. So it's really all about pressure differentials. The important thing to remember, which is a little bit counterintuitive, is that when we contract our diaphragm, it gets smaller. That creates a larger space inside of the thoracic cavity, allowing air to rush in. When we relax our diaphragm, it gets larger, creating positive pressure inside of our chest cavity and forcing air to come out. So when we divide the parts of breathing into either active or passive, knowing what I just told you, you can imagine that the active part of breathing is actually the inhalation part, because that's what we're doing when we're actually contracting the diaphragm. We're not relaxing, it's the active part. And that's pretty easily observed on yourself. Just think about when you have to take a nice deep breath. It takes some effort. When you're just sitting naturally and you want to let that breath out, all you have to do is relax. You basically relax all the body muscles, and it forces that air out. The diaphragm is not the only player in respiration, but it is the primary player. The other muscles that we use during respiration that can help increase the amount that we inspire are called the accessory muscles. And the primary accessory muscles that we have are really the intercostal muscles, which are those muscles in between the ribs. And it's also the muscles of our neck that allow basically the upper part of our chest to expand. So when we take nice deep breaths, we can witness the neck muscles in an individual starting to kind of contract. Here's just a nice summary of the exhalation process. Again, it doesn't normally require effort. When people are in respiratory distress, a lot of the time they are working on their expiration. They are inputting energy through those accessory muscles to expel air. When we get more specifically into some respiratory diseases, you'll see again why that is the case. So just a summary slide to remind ourselves how important it is that we're active in our airway, the reason why it comes first in our algorithm and as far as our assessment goes, and why it's one of the skills that you really can make a difference with. 0 to 1 minute, we have some cardiac ability, and I'm sorry, this is with apnea, so basically someone who's not breathing, there's no oxygen exchange occurring, there's no air exchange occurring in the lungs. 0 to 1 minutes, we find already that we encounter cardiac irritability. Within 0 to 4 minutes, brain damage isn't likely, so we have a little bit of wiggle room in that first 2, 3, maybe 4 minutes. As soon as we hit 4 to 6 minutes, brain damage, permanent brain damage is likely. And finally, once we get 6 to 10 minutes, it's extremely likely. Any more than 10 minutes is really irreversible brain damage and likely death, likely a cardiac arrest type event in this very, very short time frame. So this first 10 minutes is really, really that important when someone is not breathing. So I might have already used this word, but what is hypoxia? So hypoxia is basically the lack of oxygen supply to the tissues. So we want to bring in some of the oxygen through the environment, through our lungs, and through the alveoli. Hypoxia results when we don't get enough oxygen. We have basic signs and symptoms of hypoxia: nervousness, irritability, and fear. It's very natural for someone who's experiencing hypoxia, either for a respiratory complaint or for anything else for that matter, to feel anxious, to feel fearful. And that's part of our body's response to try to up the ante as far as our respiratory drive goes and try to get things moving and to counteract that hypoxia. We can find a rapid heart rate as well. Mental status changes as that hypoxia progresses, as we saw on the last slide. Use of accessory muscles for breathing. So no longer does the respiratory process look natural and consist of simple relaxation and contraction. It starts to be accompanied with significant effort. Difficulty breathing, possibility of some chest pain. So these are just general signs and symptoms of hypoxia. There are obviously going to be signs and symptoms of diseases that cause hypoxia as well. Okay, so now we're going to get into more of the practical side of airway management. You've gotten a brief overview of some respiratory anatomy. You understand how critical this is in the management of our patients. And now we'll introduce some of the tools that you're going to have. So the first thing we want to do is make sure that the airway is open. In our patient assessment lecture, we talked about the fact that when we assess the airway, the first thing we do is just make sure that the thing is open. So we have a few different methods for opening the airway, and we're going to go over them right now. So the first airway opening maneuver that we're going to talk about is the head tilt chin lift. The head tilt chin lift basically relies on the anatomy of the upper airway and the rest of the face and the mandible in order to open the airway in simply just a maneuver of the head. So the head tilt chin lift essentially is exactly what the name implies. We're going to go ahead and grab our patient's chin and we're grabbing the top of their head and we're tilting it into a hyper-extended state. So we basically hyperextend the head, and in this position it is allowing for the tongue, which generally is our #1 cause of airway obstruction in anybody that's unconscious. It removes that tongue from the back of the oropharynx and clears it out of the way of the larynx so that air can move down into the trachea. The second option is something that we call the jaw thrust. So obviously in this manipulation of my patient, the one thing I would be really worried about if they were a trauma patient would be their spine. Because as you intuitively know, moving a spine that is broken is increasing the risk of furthering that person's problem. So in our assessment, we always consider C-spine precautions when we find out about the mechanism of injury for one purpose of identifying the correct way to open their airway. So if we have identified a patient that needs protection for their C-spine, we're worried about their spine, we do not want to use the head tilt chin lift maneuver. We actually want to use what's called the jaw thrust. So the jaw thrust is another way of taking advantage of the fact that the mandible is connected to the tongue. The tongue is our primary problem when we have upper airway obstruction in unconscious patients. And so we're going to move that jaw up, and that will force the tongue up from the back of the airway. So the way that I prefer to do this method is to use the meaty parts of my thumbs just on the patient's cheekbone and grab the mandible along the curvature. I'm grabbing it with as many fingers as I can, just in front of the ears, and I'm forcing the jaw up. And that motion of moving the jaw up towards the ceiling is lifting the tongue off the back of their airway and allowing for air exchange to occur. This is obviously strenuous. As one person doing a jaw thrust, you don't have a lot of other options. You can't be involved in too many other things. And so that's part of the reason why we'll introduce a couple of what we call airway adjuncts to basically take the place of you holding that open manually. But those are our two techniques that we have for opening an airway manually. Okay, so we just briefly talked about how to open the airway. One important thing that you might find when you open an airway, especially on an unconscious patient, is that that patient's airway has stuff in it. Obviously, the higher up the stuff is, the more is blocked, and anything that's in the upper airway has the chance of moving further down into the airway, out of your reach, and still causing a problem in that person's airway. So we want to have a few techniques to get rid of the stuff that are in people's airways. Suctioning is the most obvious way. It's one of the things that is commonly forgotten in airway management, and so I encourage you to not be the norm and to think about suctioning ahead of time. Unfortunately, a lot of the time in the wilderness and in a purely a responder environment where you're not acting professionally, it's not very likely that you're going to have a suction unit with you out there. We can use physical manipulation to just orient people so that fluid and other things can drain out of the mouth, and that's called the recovery position. You'll be taught that in a different lecture. But if you do have suction available, it can be hugely beneficial in a patient who needs airway management. So really, what are we trying to do? We're trying to remove blood, vomitus, liquids, food particles, anything that we can grab onto with suction or suck up through a straw and remove from the airway so that it doesn't impede oxygen flow down inside of the lungs and result in hypoxia. Definitely in general, when we assess an airway, we're looking into the airway. We're also just from a distance listening to hear any abnormal sounds. If we ever hear gurgling in an airway or snoring in an airway, those abnormal signs clue us in to think suction and to think manipulation in terms of opening that person's airway. Different types of suction units. There's suctions that run off of oxygen tanks. There's suctions that are mounted in the walls of hospitals. There's portable suction units that run off of batteries. There are also hand suction units that are probably the more common to see in the wilderness environment. Doesn't really matter what you use, just be sure that you're familiar with it. In general, for suctioning, obviously you want to check your unit to make sure that they're functional. You want to turn that unit on and utilize the suction. Most of them will have varying amounts of suction capacity. Normally we just like to throw it on in the middle yellow range, not on the super light, not on the super heavy suction range to begin with. There are different sorts of catheters in order to actually remove the substance, and we'll see those here in just a second. So this is the hard or rigid suction catheter, commonly called the yanker or the tonsil tip suction catheter. Most of these have a little valve on the side of it that you might be able to see here on this device. That's a hole that requires it to be covered in order to function. So you can imagine if I don't have my finger there and I put this in somebody's mouth, all of a sudden there's no suction actually in the tip of it, it's just suctioning out of the side. So that's a really important feature to know about a Yankauer. In general, when we suction in people's mouths, we want to open their mouth. An appropriate way to open their mouth in order to suction is what we call the scissor technique. So we insert both our pointer finger and our thumb into the patient's mouth. On the teeth, we scissor away and open that jaw. Then we can reach in with our suction device. It's generally good to not suction on the way in. We just put the suction device all the way in as far as we can see and no further. Cover the suction and suction out in probably no more than 10 to 30 seconds per time of suctioning. We would like to be oxygenating our patient while we're doing this, and I'll show you a little bit later how you can oxygenate your patient while you're suctioning them. There are soft tip or French suction catheters. These are just flexible straws. Essentially, the one disadvantage of them is they're generally narrower than a Yankauer, and they can be occluded by somebody actually biting down. The hard ones are a little bit harder to occlude, so they'll work if someone is biting down. Just a brief mention of it while I remember to make sure I don't forget to mention it later on. You always want to be extremely careful when you insert your fingers or anything else into a patient's mouth. Obviously, in the case of airway management, it becomes a necessary evil some of the time, but just be very cautious that that patient might either react in a painful stimuli way and bite down on your fingers, or might have some sort of underlying pathology that causes them to be clenched and to want to bite down. So just be very, very careful whenever inserting anything into a patient's mouth. So yeah, do it quickly, don't waste your time suctioning. Remember that while you're suctioning, that person is not getting optimal oxygenation, and you are inducing a certain amount of hypoxia. Obviously, if there is blood, vomitus, anything in the airway, that risk outweighs the risk of inducing a bit of mild hypoxia. Okay, so now we're going to move on to talking about the airway adjuncts. So I mentioned before, as a single person, doing a manual airway openings technique can be very exhausting, and it's resource intensive. So we'll show you a few tools that can help in keeping an airway open so that you can do something else. So now we're going to introduce the oral and nasal adjuncts. So the first one we'll talk about is the oral. This is the OPA, or oropharyngeal airway. And this airway is a nice way to keep that tongue back up off the back of the throat and ensure that we have oxygenation of our patient. So the first thing we need to do is figure out how to size these things. So I have a few different sizes here. A lot of the times you'll see that these kits commonly have different colors for the different sizes. It's not always the case. Every OPA is different. So don't get too focused on the color. Don't get focused on the number that they indicate. Just get focused on how to actually measure these things out. So when we measure the OPA, we want to measure basically from the corner of the ear to the corner of the mouth. So if I take my OPA, I'm going to grab the wrong size first to demonstrate, and I put it on the tip of the ear and over to the corner of the mouth. I notice that this one goes all the way towards the middle of the mouth. That's a little bit too big. That's going to go too far into that patient's airway. So I'll discard that one. I'll get a different size, slightly smaller. Again, from the corner of the ear over to the corner of the mouth, that looks like a pretty ideal size. So now that I have the correct size of OPA, it's important for me to insert it correctly. In order to insert it correctly, the first thing I want to do is simply open the mouth, just as I showed you when doing the suctioning. So a simple scissor technique will help open the mouth. When I take my OPA, the natural tendency is to just push it in the way you might want to. The best way to do it is actually insert it at a 90-degree angle to the mouth, moving along the curvature of the inside of the mouth until you're about halfway. At that point, I can start to rotate into position for the last few centimeters. This is a nice position to have it in because while you're inserting it into the oropharynx, the tendency is not to push the tongue back into the posterior oropharynx. This allows you to manipulate through the curvatures of the inside of the mouth. When I would like to remove an OPA, you don't really need to do the same thing backwards. You simply move it out along the anatomy of the mouth. So that's the OPA, oropharyngeal airway. The important thing to note about an OPA is that you can only use these in patients that do not have a gag reflex. So to determine whether or not a patient has a gag reflex, obviously anyone that's awake or slightly awake is going to have a gag reflex. The other way to note if they do not have a gag reflex is by simply brushing your fingers along the patient's eyelashes. If they have a reflex, they twitch their eyes, that means that a gag reflex is likely intact, and we do not want to use an OPA. So what do we use if we can't use an OPA? Well, we have another airway device called an NPA, which is a nasopharyngeal airway. So this essentially creates a nice open hollow tube from the nasopharynx down into the back, essentially into the larynx, just below the oropharynx. So when I select my appropriate NPA, it's very similar to sizing the OPA, but since we're using the nose, we go to the corner of the nose instead of to the corner of the mouth. So again, from the corner of the ear to the corner of the nose, and that's going to be roughly the correct length of NPA. NPAs are flexible, but that doesn't mean that they can't do damage. Inside of your nasal cavity, inside your nasopharynx, you have a few very small sensitive structures that are called turbinates. And these guys are very fragile and can easily be injured by anything moving in through the nose. So we always want to be delicate when we're inserting NPAs. In general, we like to position this NPA in a specific way. So as you can see, the NPA has what we call a bevel. So it's not a flat tip, it is a beveled tip. The bevel we want to keep towards the septum. So basically the idea here is that some of the more important structures of the nose are towards the septum of the nose, which is the inner side, basically the middle of our nose. And so we want to keep this tip away from those structures. So in order to do so, if I would like to insert my NPA into this patient's nostril, I would start just the first few centimeters with the bevel towards the septum. And as I was moving into the nose, quickly I want to rotate that so that the obvious anatomical direction of the NPA follows the back of the nose into the mouth. Because essentially we do not want to insert the NPA fully like this. We would prefer that NPA to follow the curvature of their nasopharynx and to sit in the back of their throat, just like that. So if I were picking this patient's right nostril, bevel towards the septum would be the natural position. So please ask any questions if you guys have confusion about the bevel and the orientation when inserting the airway. It's not the most important thing, but if it's one thing that you can remember while you're performing this procedure, you'll be better off. So obviously, when we insert a nasal airway, we're worried about the things that are going on inside that person's face. So a patient who might not be a candidate for an NPA would be someone who has very, very broken nose. Someone who their nasal airway looks like it's broken. There's a lot of facial fractures. This patient, we really don't want to be inserting anything in and possibly pushing on any kind of weakened structures. Another consideration to take when using an NPA is that we need to use lubrication. So an oral airway, not so important, but whenever we use a nasal airway, heavily lubing that device before inserting it into the nostril is very, very important. Once we have the NPA in place, and this mannequin is not well lubed, so it's fighting me a little bit. Once we have that NPA in place, if we would like a little bit more of an open airway, there's not any reason why we can't put another nasal airway in. I do not have the correct size of airway to demonstrate the second airway, but essentially I can put a small one in here just to demonstrate what that would look like. And this is essentially two NPAs in the same patient, allowing for a more significant airway in one that is compromised. So just a nice summary of an NPA, the advantages and disadvantages of an NPA. A nasopharyngeal airway can absolutely be used in conscious patients. This doesn't mean that they're enjoyable. It doesn't mean that any patient that we see needs an NPA, but those that we're worried about maintaining their airway and who are difficult to oxygenate can definitely be candidates for NPAs. They can be used for patients that have an intact gag reflex. So even if we note that this patient has a gag reflex by the fluttering of their eyelashes, then we can still use an NPA. But absolutely, we should not use NPAs on patients that have significant facial fractures or what we call basilar skull fractures. These patients are at risk of further damage from an NPA. So we're going to talk for a minute here about a more invasive airway for you guys. So it's currently being revised, and I actually haven't heard the final word of whether or not they're going to take the LMA, the laryngeal mask airway, out of the first responder scope in New Mexico. That being said, I believe it's still in the national scope for the first responders, so it's something relevant and worth talking about. But essentially, it's the more advanced airway that you might have access to as part of a search and rescue team. This is not something that you're going to be carrying on your own. The wilderness medical lecture will kind of deal with the medical legal lecture will deal with some of the reasons why you would never have one of these on your own. But it might be a tool that you could use, so it's a good thing to be familiar with. Essentially, the LMA has been used forever in anesthesia, inside of operating rooms. It's also working its way nicely into the emergency medical services side of things, and even inside of the emergency room. The newer generation LMAs are much better than the original LMAs. They offer a significant amount of protection from what we call aspiration. So you might see on this slide, does not protect from aspiration due to emesis. Well, that's kind of true and it's kind of not true. The current ones are doing a much better job of preventing against aspiration, and there are other adjuncts you can use with an LMA to further prevent the risk of aspiration. So definitely a good tool, a more secure airway, and you'll see here in a little while why these things can definitely take a load off of your resource intensiveness when you're coming to treating a patient in the backcountry. In general, the LMA is going to consist of two parts. We have the tube and the mask. So the tube is the part of the LMA that allows the air to flow through, and the mask, which is going to create the seal basically right in that larynx, right on top of the trachea and right on top of the esophagus. Here's a nice little diagram of an LMA properly placed. As we can see, the tube comes in through the oropharynx, back down into the larynx. The mask here sits just on top of the larynx, and the very, very tip of it sits nicely into the esophagus. So this is where we actually get a bit of protection in the modern day LMAs, is that these tips are a little bit more aggressive, and they really do a decent job of preventing any kind of vomitus or anything from the stomach contents of coming up through the esophagus into the trachea. That's what we refer to when we use the word aspiration. I apologize if I didn't clarify that before. So, indications for use of an LMA. Patient cannot have a gag reflex. You can imagine on that last picture that if I tried to put an LMA down your mouth, you'd very, very readily gag. So it has to be an unconscious patient with no gag reflex. Situation involving a difficult BVM fit. So we haven't talked about the BVM yet, but we're about to. And the BVM is basically our device that we use to supply ventilations that are not mouth-to-mouth. It's a bag valve mask. It's a simple way to provide ventilations. Normally you can use the mask to fit on-side the face just like a typical CPR mask, but in the case where that would be very, very difficult to maintain, essentially any environment in the backcountry when you're going to be removing a patient from the environment and transporting them while assisting ventilations, you really need a better device than just a BVM and a mask. Anything that's a long transport for the same reasons, they also can be used with transport ventilators, which is nice because then the rescuer themselves don't have to apply the respiration. You can have a ventilator do that for you. Equipment for insertion that you're going to need. The LMA of an appropriate size. Every LMA is a little bit different. Their numbers are standardized, but the most important thing is to know how to figure out that it's the right device. On this one, I'm going to simply look through the information on the label and note that this LMA is correctly sized for a 30 to 50 kilogram person, and that is the size 2.5 for this particular device. The devices generally on the actual LMA themselves will also have that same information. So this LMA is Supreme, different brand than the AirQ blocker. This is a size number 4. It's for 50 to 70 kilograms. So just knowing that the patient's weight in kilograms is what's going to help you determine the size of LMA is really the most important feature there. You also need lubricant, just like you would need lubricant for an NPA, you need lubricant for an LMA. You also need a syringe of an appropriate size to supply the air to the mask. The amount of air is generally provided in cc's of air. So obviously this is a syringe that has cc's, cubic centimeters, or milliliters. Those are the same unit, they're the same size. And so it will either say, this one specifically says air less than 45 milliliters. So I want to use just slightly less than 45 milliliters of air. I can, on my nice syringe, simply drop that amount and insert it into the LMA. I'll show you that specifically here in a minute. So in conjunction with the device itself, we need some sort of method to supply ventilations, and that would be our BVM. Stethoscope is essential, and a stethoscope is for confirming that our LMA is correctly placed and that we are actually inflating the lungs. And tape or some sort of commercial device for securing the device is important as well. So initially, I'm just going to run through this nice and quickly, and then I'll give you a nice demonstration of the insertion of an LMA at the end. We always want to visually inspect the cuff. We want to make sure there aren't any leaks. We want to fill it with air and then deflate it to ensure that when there's air inside of the cuff, it will hold air inside the cuff. We want to make sure that it's not damaged along the tube as well. In order to insert it the least invasively, we want to deflate the cuff when we insert it. Once that thing is completely inside the mouth and just sitting right on top of the larynx, that's the time when we want to inflate the cuff. You can see this would be the ideal deflation configuration of an LMA, where the tips are sort of folded back. This will provide the least amount of resistance on insertion. So the nice thing about an LMA, and one of the reasons why the state of New Mexico has historically allowed wilderness first responders and first responders alike to use an LMA, is that they're incredibly easy to insert. They don't take a lot of technique. Just a few good, simple techniques will get you a long way with an LMA. Essentially, it's the best to grab the LMA towards the base where the mask is and insert it along a couple of fingers all the way down into the mouth. Essentially, you're just shoving this device into the patient's mouth while making sure that the tongue does not get in the way. That's the basic principle of it. I'll show you a little bit more sophisticated way to think about it here in a minute. Once you get all the way down into the larynx, you can stop inserting the NPA, or I'm sorry, the LMA, and that's when we want to hold it in place and allow either ourselves or our partner to inflate the cuff. Once we inflate the cuff, we have to verify that the tube is correctly placed. And the way we do that is we use our stethoscope. So we want to use our stethoscope to auscultate lung sounds, so we can put the bell of our stethoscope on the patient's left and right chest in multiple locations along their lungs. In the next lecture, you'll learn the specifics of auscultation, and that will help you identify that air is moving in and out of the lungs. We also want to auscultate just above the stomach. And the best place to find that is essentially right above the navel, and that we're listening for epigastric sounds. We're listening to any kind of air moving down into the GI tract, and we don't want a lot of that. Okay, so I'm going to quickly demonstrate the insertion of an LMA. Obviously a skill you'll get to practice in your airway lab day, but just a nice quick demonstration I'll be narrating as I start. So, first thing I want to do is choose the correctly sized LMA. Ensure that the LMA is 50 to 70 kilograms. My patient, I'm estimating, is somewhere between 50 and 70 kilograms. I also find on the LMA that I need to insert about 45 milliliters of air. So I take my syringe, I withdraw to around 45 milliliters of air. I insert the tip of the syringe into this reservoir. I inflate the cuff. I detach my syringe and ensure that the integrity of my LMA is still intact. I can also check the integrity of my bulb of the mask by pressing gently on this bulb, and it should reinflate nice and vigorously, which it does. So now that I have that, I want to deflate my LMA, ensuring that I get as close to a clover as I can. And I'll just simply push the sides of the material so that I get a decent clover. Now, it's definitely reasonable to leave the syringe attached when I go for insertion so that I don't have to do that later. hopefully my partners or I myself have been pre-oxygenating my patient. So we've been using a BVM with an OPA. We've at least been giving them some oxygen with a face mask. We'll talk about that here in a moment. But we want to make sure that our patient is what we call pre-oxygenated. So if we have an oxygen saturation, their oxygen saturation is above around 93%. That can change depending on the person, but that's kind of our general overall goal. When I'm ready to insert my LMA, I want to make sure I lubricate the tip on both the inside and the outside. And now I'm ready to insert my device. Just like I did before, I want to use the scissor technique to open the mouth, grab the base of the LMA. I'm inserting the LMA so that the top of the LMA is really just gliding along the roof of that patient's mouth. And I'm inserting the LMA all the way until I meet considerable resistance. I've met considerable resistance. I hold the tube in place. I take my syringe. I inflate the cuff while also ensuring that the syringe itself is not allowed to inflate again. I disconnect the syringe. And now I need to confirm my tube placement. So I want to find my BVM. I want to attach my BVM to the tube and inflate my BVM. At this point, either I or my partner will be listening for lung sounds. We hope that lung sounds are present bilaterally. We also hope that there are no epigastric sounds. So we're listening for any kind of air moving into the stomach, and we hope that we do not find any. If we don't have great if we don't have great ventilation, one thing we can do is deflate the cuff slightly, move back our tube about 1/2 centimeter, reinflate the cuff, and recheck our ventilations. That might improve the fit. If you do that once or twice and you still do not have a good seal, at that point when we remove the LMA, we need to be sure to deflate the cuff before we pull it out of the patient's mouth. Cuff is deflated, detach my BVM, and remove the NPA along the curvature of the patient's mouth. At this point, I could revert back to bag valve mask ventilations with simply a mask, maybe an OPA, and either get a different size or have a different person attempt the LMA. So we've obviously covered a lot in just the first half of part 1 of respiratory emergencies. So I will take a break, you can take a break, and we'll come back to discuss supplemental oxygen, bag valve mask techniques, and just some general overall ventilation considerations.